Hey guys, how are you all? Welcome back to MedSteps YouTube channel. So today in this video we are discussing about first aid series episode 5. We are discussing about anterior dislocation of the shoulder and some like rotatory cuff syndrome. Okay, so first of all, what is anterior dislocation of the shoulder? If any patient, most commonly we can see in shoulder, most commonly we can see the anterior dislocation. And this anterior dislocation, if you are seeing this image, okay, if you are seeing this image, you can see here this is the shoulder. In this shoulder we have to focus on glenohumeral joint. This is the glenohumeral joint. Okay, in this glenohumeral joint, this is the most commonly dislocated joint in the body due to the shallow articulation. If you are seeing this image, it's like very shallow. Okay, because of this shallow articulation of the joint between the humeral head, this is humeral head, and some glenoid fossa of the scapula. This part we call glenoid fossa of the scapula. These things, because of that shallow articulation, it can cause dislocation. Okay, so how many types of dislocations we have in shoulder? Mostly total 3 types, like anterior dislocation, and we can see like inferiorly dislocation and posteriorly dislocation, but most common is anterior dislocation. Okay, and why this is most common means because most commonly 95% of shoulder dislocation we can see only anterior dislocation. Okay, and here because of this dislocation, what will happen? It will mostly caused by this anterior dislocation caused by this anterior dislocation mostly caused by like a blow to an external rotated and abducted arm. If any person like pulling, like sudden pulling, then you can see the anterior dislocation. Okay, in the head, mostly if you are seeing this head of the humerus is displaced anteriorly, and it's like because of this anterior dislocation, here we can see that is we call the deltoid prominence. Then that deltoid prominence will be like flattened. And why? Because here from back of, like from here you will get one nerve, that nerve will come inside the backside beyond the humerus surgical neck, and it will come to the beyond the surgical neck of the humerus. What nerve? Which nerve? That is axillary nerve. Okay, this axillary nerve is mostly innervated to the deltoid muscle and teres minor. Okay, deltoid muscle and teres minor. Okay, if anything dislocation happen means that axillary nerve will get like stretch, or because of sometimes that axillary nerve will get tear. Okay, because of the thing, the humeral head because of the humeral head dislocation, then we can see most commonly like the teres minor and deltoid muscle will get like weak shoulder abduction, and it provides like some asensation like to the lateral side of the deltoid muscle. Okay, and sometimes like deltoid atrophy also we can see, like flattened of the deltoid vessel after a shoulder injury, it can suggest anterior shoulder dislocation. If any patient coming with deltoid atrophy or flattened deltoid muscle or weakness and abduction of the shoulder, okay, like deltoid muscle is the main function is 15 to 90 degrees, it can abduct, it can do the range of motion of the abduction. If this things is not like doing getting problem with doing means, then we have to think that is the anterior dislocation of the shoulder. So when it's coming to X-ray, if you are seeing this image, when you are seeing this image, you can see here, this is the X-ray. This humeral head is came forward. So, because it came forward, that is why we have to think this is the anterior dislocation. So, what we have to do? We have to do X-ray imaging of the anterior, posterior and lateral view. Okay? And in some patients that develop recurrent dislocation also we can see with minimal trauma. Okay? So, I am repeating another time. So, anterior dislocation is the most common. Most commonly we can see the 95% of anterior dislocation in shoulder, because in anterior dislocation mostly we have a risk for axillary nerve, because that axillary nerve is mostly innervating to the this axillary nerve is innervating to the deltoid and teres minor muscle, and because of this thing, if any in anterior dislocation we can see the anterior axillary nerve will get stretched. Because of that stretch, we can see flattened muscle and deltoid atrophy and shoulder weakness in abduction. Okay, so these are the things we can see in anterior dislocation, and patients hold arm in slight abduction and externally rotation. Okay, if you are seeing that image in X-ray, these are the things we can see. Okay, now when it is coming to posterior dislocation, this is the posterior dislocation. That means that humeral head came back, went back. Okay, so for this thing, what we can do in posterior dislocation, it's very rare. Okay, and mostly it's associated with some seizures or electrocution. Okay, patients hold arm in adduction and internal rotation. If any patient's arm will be like adduction and internal rotation, then we have to think that is posterior dislocation of the shoulder. Okay, if any patient have like abduction and external rotation, then you have to think about anterior dislocation. Okay, so what management we can do for this patient means we have to do reduction, and we have to use some sling or swath, and we have to if patient getting like recurrent dislocation like always, then we have to, with minimal traumas or always it's that patient getting dislocation, then that patient may need surgery. Okay, next one, rotatory cuff syndrome. So I already mentioned, I already discussed in first aid series in episode 1. I discussed with like rotatory cuff muscles. So if you didn't watch that video, so please go and watch, then you will get like a good idea about this rotatory cuff muscles. Okay, mostly in rotatory cuff is made up of tendons. The tendons we call like supraspinatus, infraspinatus, subscapularis and teres minor. Okay, so here if the tendons of this rotatory cuff muscles along with the glenohumeral joint ligaments and the tendon of the long head of the biceps brachii muscles and contributes to the stability of the glenohumeral joint. So we have some ligaments, and these tendons will help for forming the stability to the shoulder. Okay, if you are seeing this image, you can see here this is clavicular bone and some acromioclavicular joint, and this is the supraspinatus tendon, and infraspinatus is the back of this you can see scapula, and we can see like some deltoid bursa and deltoid muscle. Okay, so here in rotatory cuff syndrome, mostly in rotatory cuff structures, mostly this is the very important muscle. Okay, because most commonly affected in rotatory cuff syndrome any muscle means that is supraspinatus. Why? Due to superior location. Okay, and tendon is like vulnerable, like if any patient is doing chronic repeated getting like trauma or from like impingement because of too much work, or like if any the patient have like occupation like painting or sealing, so this patient can get this rotatory cuff syndrome. Okay, and this impingement between the head of the humerus and like here this acromioclavicular joint. Okay, that this supraspinatus will getting like impingement, and if it's going to in this area, of the space, that muscle, the tendon is going in between the acromioclavicular joint, then that tendon will get impingement. Because of that impingement, we can see this rotatory cuff syndrome. Okay, so what we can do, how we can diagnose this patient means we have to do some, we have some special test like MT can supraspinatus test. This is like 90% of specific for supraspinatus like pathology. We have to tell the patient abduct arm to 90 degrees and we have to flex arm to 30 degrees. Okay, if you are seeing this image, you can understand very easily. And we have to point the thumb down toward ground, and like some we are pouring some like canned drink. Okay, and we have to resist, the examiner have to resist, and we have to apply some downward force. Okay, then the patient will get unilateral pain, or the patient will feel some weakness in that shoulder, in that arm. Okay, so in rotatory cuff syndrome, we can see two types of things, that is rotatory cuff impingement or tendinopathy. Tendinopathy means the tendon is not working properly, then we can call that is the tendinopathy. So mostly we can see supraspinatus. I already mentioned, if any patient doing like painting and sealing work, they are most common like affected with this middle aged people and older individuals. Okay, this rotatory cuff itself, it will cause pain, may also like emanate from the subacromial bursa and the tendon of the long head of the biceps. Okay, next, on flexion or abduction of the humerus, the space between the humeral head and acromion is reduced, causing pressure on the supraspinatus tendon and subacromial bursa. Okay, next one, if you are seeing this thing, next, rotatory cuff tears. If you are seeing this image, you can see here, this is the supraspinatus muscle. Okay, and this supraspinatus muscle got tendon, like that supraspinatus tendon got tear. Okay, how? If that supraspinatus is most commonly injured due to degeneration of the tendon with age and repeated movements and ischemia induced like impingement between the humerus and the acromion during abduction. Why? If any this supraspinatus is like we can see in superior, and if any patient getting like degeneration in acromioclavicular joint, in that acromioclavicular joint we can see some space, that means here, because of that space, that while moving that hand, while doing abduction and adduction, that time that supraspinatus will go and it will go in between that space of the acromioclavicular joint. Then because of, we can see some impingement. If any impingement is there means then that part will get ischemia. Because of ischemia, that part will not get, that tendon will not get enough blood circulation. Because of that enough blood circulation, it can cause tear. Okay, so a complete supraspinatus tear causes like weakness of abduction, and which can be appreciated in the drop arm thrust. Okay, so if you are seeing this image here, the supraspinatus got tear. Okay, now I am going to discuss about arm drop test. This is very special test for rotatory cuff tear. Okay, in rotatory cuff, in rotatory cuff tendinopathy means we have to do that can test, empty can test. When we are coming to rotatory cuff tears, then we have to do arm drop test. In this test, the patient arm is abducted above the hand and the patient is asked to lower the arm slowly, okay, with a complete tear. If any patient have with a complete tear, the patient will be unable to lower the arm smoothly and it will drop rapidly around mid adduction. Okay, so the supraspinatus is the primary muscle responsible for initiating the first 15 degree of abduction. The loss of smooth adduction in the drop arm test typically occurs when the humerus is near the horizontal plane. Okay, so for supraspinatus tear, the tendon tear, what for diagnosis, what test we can prefer? This is like golden standard test for like any tendon related things and ligament related things. Then we have to do MRI, because MRI can confirm the diagnosis of the suppressed this rotatory cuff tears. Okay, so here for sometimes we can if the treatment is usually required, then we have to do some surgery also. Okay, so I am giving like some like brief things about rotatory cuff tear. This is acute onset of anterior shoulder pain. The patient will get acute onset of shoulder pain and weakness with the abduction and external rotation of the humerus after fall on like outstretched arm or in young athletes also, because of repetitive movements, or we can see some impingements. So the significant shoulder stiffness in patients with dermomyositis. Okay, so for diagnosis I already mentioned that we have to do MRI. So when it's coming to treatment, we have to give rest to the patient, and we can start with NSAIDs for like minor surgery, and if surgery, if loss of active range of motion and with preserved passive range of motion, then we have to do some we have to do the surgery. Okay, so in this first aid series in episode 5, today we discussed about anterior dislocation and rotatory cuff syndrome. In rotatory cuff syndrome, we saw like two conditions. First one, rotatory cuff impingement, or we can call tendinopathy, and rotatory cuff tears. Okay, so we will meet in our next video. Take care. Bye bye.